Tampa Bay spent 5 years perfecting a pitch that real estate agents, brokers, and county tourism boards could all recite from memory. Retire here and you get the Florida lifestyle without the Miami price tag. Affordable housing, accessible beaches, and the kind of Medicare drug coverage that turned prescription costs into an afterthought. The message worked because the numbers backed it up. Between 2019 and 2023, Hillsborough and Pinellas counties added more than 60,000 Medicare beneficiaries. Not snowbirds keeping dual residency. Full-time residents switched their primary address because Tampa Bay promised them security they could not find anywhere else. Enrollment events at senior centers turned into standing room-only affairs where retirees compared Part D plans the way they used to compare mortgage rates. The competition was fierce and visible. A dozen standalone drug plans per county, half of them advertising $0 premiums with insulin caps and reasonable formularies. The region marketed itself as the smart choice for middle-income retirees. Not the wealthiest seniors fleeing state taxes, not the poorest relying entirely on subsidies, the ones in between. Teachers, mid-level managers, and tradespeople who built modest nest eggs and wanted them to last. Tampa Bay told them they could stretch a fixed income further here than in Atlanta, Charlotte, or anywhere up north. Lower property taxes, cheaper groceries, and drug plans that covered name-brand medications without the prior authorization nightmares they heard about from friends in other states. Every broker in the region used the same closing line. You are making the right choice because Tampa Bay has the best drug coverage in Florida, and Florida has the best drug coverage in the country. That line closed thousands of enrollments. It worked because for a brief window, it was actually true. What no one mentioned was how fragile the foundation was. The benefits were not generous because Tampa Bay had solved some secret formula. They were generous because carriers were in a race, where pulling back meant losing market share instantly. The model only worked if growth continued forever and drug costs stayed predictable. Neither assumption was safe. Nobody said that part out loud. The Inflation Reduction Act looked like a victory when it passed. Insulin caps, out-of-pocket limits, and a promise that seniors would never face catastrophic drug costs alone again. Every news segment framed it as relief. Politicians cut ads celebrating it. What those mailings did not explain was where the money came from. The law capped what seniors paid. It did not cap what the drugs cost. Someone still had to cover the gap, and starting in 2025, that someone was the insurers offering Part D plans. The federal government restructured the catastrophic threshold so carriers absorbed a far larger share of high-cost medications. On paper, this protected seniors. In reality, it transferred the financial bomb from beneficiaries to the companies that had been banking on the old payout structure. The rule change was public. The implications were not. Tampa Bay's demographics made the problem worse. The region had not just added retirees, it had added exactly the kind of retirees who drove drug spending into dangerous territory. Older beneficiaries on multiple chronic medications, cancer survivors requiring ongoing specialty drugs, diabetics using newer GLP-1 treatments that cost insurers thousands of dollars per member per year. The same middle-income seniors who made Tampa Bay attractive as a market were the same ones whose drug regimens carried the highest actuarial risk. Carriers knew this. Their underwriting teams ran the models in early 2024 and saw the curve bending in the wrong direction. More members meant more revenue, but it also meant more exposure to the exact medications the Inflation Reduction Act had just made exponentially more expensive for plans to cover. Growth was not solving the risk, it was concentrating on it. The silence from carriers was deliberate. No insurer wanted to be the first to signal trouble because doing so would spook both regulators and the market. Internal emails circulated among actuarial departments, but external communications stayed optimistic. The strategy was simple: delay the reckoning as long as possible and hope another carrier blinked first. The 2024 enrollment period finished smoothly because no one wanted to disrupt it. Carriers collected premiums, brokers collected commissions, and seniors thought their coverage was locked in for another year. The real reckoning was scheduled for October 2024, when the 2025 rates would go public. October 1st, 2024, at 7:15 in the morning, the Centers for Medicare and Medicaid Services released the approved Part D premium rates for 2025. Brokers in Tampa Bay opened their rate sheets expecting the usual adjustments. A few dollars here, maybe a 10% bump on the high end, nothing that would break the conversation. What they saw instead made them refresh the page 3 times to confirm it was not a system error. The most popular standalone drug plan in Hillsborough County, the one that carried nearly 40,000 members at a $23 monthly premium, had jumped to $44.50. a 94% increase in a single year. Pinellas County's top enrolled plan went from $18 to $35. Pasco saw a formerly $0 premium plan leap to $28. Every major carrier, every competitive plan, every option that had defined Tampa Bay's drug coverage advantage had effectively doubled overnight. The dollar amounts hit different depending on where a retiree stood financially. A senior on a fixed $1,500 monthly Social Security check suddenly faced an extra $300 annually just to keep the same drug coverage. A couple juggling two Part D premiums saw their combined cost rise from $40 a month to more than $80, carving another $500 out of a budget already stretched thin by inflation on groceries and utilities. The math was brutal and immediate. Retirees who had carefully planned their retirement income around predictable healthcare costs found themselves recalculating everything. The increase was not a line item. It was a crisis that required choosing between prescriptions, groceries, or utility bills. Hillsborough saw the steepest increases because it carried the densest concentration of Medicare enrollment, while Pasco and Hernando lost their budget-friendly advantage entirely when their previously low-cost plans spiked into the same range as everywhere else. Carriers issued statements within hours blaming the Inflation Reduction Act's restructuring of catastrophic coverage and rising specialty medication costs. The explanations were technically accurate and completely useless. Seniors did not need to understand actuarial formulas. They needed to know why the plan they enrolled in 11 months earlier at $23 now cost $44. The carriers never said the quiet part out loud. The old premiums were never real. October 15th, 9 in the morning, the first day of the Medicare annual enrollment period, and Shine offices across Tampa Bay were already underwater. Volunteers who normally handled 20 calls a day fielded 60 before lunch. A retiree in Clearwater called to ask if the 94% increase was a typo. A couple in Brandon wanted to know if switching to Medicare Advantage would save them money or trap them in a worse network. A woman in Town and Country repeated the same question 3 times because the answer made no sense to her. How can the premium double if the government said costs were going down? The Shine counselors had scripts, comparison tools, and decades of combined experience. None of it mattered. There was no good answer. Every option available in the system was either more expensive, covered fewer drugs, or required switching pharmacies and doctors mid-treatment. By the end of the first week, counselors stopped trying to be optimistic. They just walked people through the least damaging choice and moved to the next call. Brokers faced the same flood from a different angle. A retired electrician in Riverview asked his agent how a $0 premium plan could jump to $28 when nothing about his health had changed. The broker pulled up the rate sheet, confirmed the number, and tried to explain the Inflation Reduction Act's impact on catastrophic coverage. The client cut him off. "I do not care about Washington. I care about my budget. Can you find me something cheaper?" The broker ran the search. The cheapest plan in the client's zip code was $31 and covered half the pharmacies the old plan did. The next option was $26 but required mail order for maintenance medications and prior authorization on 2 of the client's 4 prescriptions. There was no good news to deliver. Every conversation ended the same way. Do you want to switch to one of these, or do you want to pay the increase and keep your current plan? The math problem played out in real time across kitchen tables in every Tampa Bay county. A retired teacher in St. Petersburg sat with her husband and a calculator, trying to make $44 a month fit into a budget that had no room left. They had $1,512 in fixed income between 2 Social Security checks. Rent was $900. Utilities ran another $140. Groceries were pushing $300. The old drug premium at $23 had been tight but manageable. At $44, something else had to give. They called the Shine hotline and were put on hold for 38 minutes. When someone finally answered, the counselor confirmed what they already knew. There was no plan in their price range that kept their current pharmacy and formulary. The coverage they had relied on was gone. The choices left were all bad. The premium spike did not distribute its damage evenly. It found the exact demographic that Tampa Bay had spent years recruiting, and it hit them harder than anyone else. Middle-income retirees living on fixed pensions, $2,000 to $3,000 a month. Not poor enough to qualify for Medicare low-income subsidy. Not wealthy enough to absorb a sudden $500 annual increase without consequence. The subsidy cutoff sat at $19,030 in annual income for a single person. A retiree making $19,050 got nothing. No premium help. No cost-sharing reduction, just the full weight of the increase and a bureaucratic letter explaining they earned too much to qualify for assistance. The gap between barely too much and barely enough was $20 a year. The penalty for falling on the wrong side of that line was hundreds. Geographic concentration told the story in data. Zip codes in South Tampa carried some of the highest Medicare enrollment rates in the county, and they absorbed premium increases that averaged 98%. Carriers priced plans based on actuarial risk in a given area, and neighborhoods packed with retirees on multiple medications represented the highest risk pools in the region. The premium hikes were not random. They were precision instruments designed to either drive out the risk or make it pay for itself. Seniors living in these concentrated zones faced the realization that their neighborhood itself had become a liability in the eyes of the insurance industry. The governor's office issued a statement 3 days after the premium rates went public. Strongly worded, carefully structured, and aimed directly at Washington, the statement blamed the Inflation Reduction Act for destabilizing Florida's Medicare drug market and called on federal regulators to provide immediate relief. It praised Florida's commitment to protecting retirees and criticized the Biden administration for implementing cost-shifting policies that punished states with high Medicare enrollment. The statement did not mention that Florida's own economic development strategy had been built on recruiting those exact retirees. The message was clear: this is not our fault. Washington broke the system, and now Florida's seniors are paying the price. Carriers responded with their own version of blame deflection. Every major insurer released nearly identical statements citing the Inflation Reduction Act's reinsurance changes as the primary driver of premium increases. They pointed to the new catastrophic coverage rules that shifted liability from the federal government to private plans and argued that the increases were necessary to remain solvent. The statements were technically accurate and strategically useless. They explained why the carriers had to raise premiums. They did not explain why the premiums had been artificially low in the first place. Federal regulators pointed to national data showing that average Part D premiums had decreased slightly in 2025. They emphasized that premium adjustments in certain high-cost regions were an expected part of market stabilization. Florida's pain was the result of Florida's previous success. The state had enjoyed years of unsustainably low premiums, and now the market was correcting. What none of them said was the part that mattered most. The math had never worked. The old premium structure was not a sustainable market equilibrium. It was a temporary illusion held together by federal subsidies, carrier competition, and the assumption that drug costs would not spike as fast as they did. Everyone involved knew the model was fragile. Nobody wanted to admit it because admitting it would mean acknowledging that the entire premise of Florida's retirement economy had been built on a financial structure designed to collapse. Tampa Bay was not an outlier. It was a preview. Every region in the country that had built a retirement recruitment strategy around Medicare drug coverage was watching the same actuarial clock tick toward the same endpoint. The villages in Central Florida saw premium increases averaging 87%. Sun City in Arizona hit 92%. Retirement communities along the Carolina coast absorbed spikes between 70 to 100% depending on county. The pattern was identical everywhere. High Medicare density plus aggressive carrier competition plus Inflation Reduction Act cost shifting equaled unsustainable premiums. The regions that had won the race to attract retirees were now paying the price for winning. Economists started calling it the density penalty. The more successful a region was at concentrating Medicare beneficiaries, the more expensive it became to insure them. Tampa Bay had not failed. It had succeeded so well that the market could no longer support the outcome. By early 2025, experts were already modeling the 2026 enrollment cycle, and the predictions were worse than the current crisis. The catastrophic cap changes were being phased in over multiple years. The 2025 increases reflected only the first wave of cost shifting. Additional liability transfers were scheduled for 2026 and 2027, meaning premiums would likely rise again even if drug costs stayed flat. Actuarial firms hired by carriers ran scenarios showing that standalone Part D plans in high-density regions could see cumulative premium increases of 150 to 200% by 2027 compared to 2024 baselines. The 2025 shock was not the crisis, it was the warning shot. The death of affordable drug coverage as a retirement selling point was already visible in real-time market data. Financial advisors who specialized in retirement relocation planning started telling clients to reconsider Florida unless they had substantial cash reserves. The calculation that had made Tampa Bay attractive, low cost of living plus manageable healthcare costs, no longer balanced. A retiree comparing Tampa to North Carolina or Tennessee now faced similar or higher drug premiums in Florida with the added risk that those premiums would keep climbing. The value proposition had flipped. Florida was no longer cheaper, it was riskier. And risk was exactly what retirees on fixed incomes could not afford. Every retiree currently sitting in Tampa Bay trying to decide whether to stay or leave was running the same calculation. How many more years can I afford to live here before the math stops working? The ones who could leave were starting to. The ones who could not were stuck watching the system erode around them with no backup plan and no one coming to help. By 2025, the enrollment numbers told a story that no press release could spin. Tampa Bay's four-county region saw a 12% drop in standalone Part D enrollment compared to the previous year. Nearly 47,000 members either switched to Medicare Advantage plans, moved out of the region, or dropped drug coverage entirely. For the first time in more than a decade, Medicare drug plan enrollment in Tampa Bay shrank instead of grew. 60% migrated to Medicare Advantage options. 20% moved their primary residence out of Florida entirely. The remaining 20% stopped paying for drug coverage at all. Too expensive to keep. Too healthy, they thought, to need it. The calculus for new retirees considering Tampa Bay changed overnight. Financial planners who used to recommend the region as a cost-effective retirement destination started running different scenarios. Tampa's drug premiums were higher, likely to rise further, and concentrated in a market showing signs of carrier retreat. The advice was changing. Consider other options. Do not assume Florida will stay affordable. The gap between coverage that existed on paper and coverage that was actually usable widened every month. Seniors scrolling through plan comparison tools still saw a dozen options listed, but once a member entered their specific drug list, the options collapsed. The plans existed. They just did not cover the drugs people actually needed at pharmacies they could actually reach. Tampa Bay's drug coverage crisis was not a temporary disruption. It was a permanent reset. The premiums that jumped 94% in 2025 were not going back down. The plans that exited were not coming back. The system that existed in 2024, where retirees could choose from a dozen affordable plans with broad formularies and wide pharmacy networks, was gone. What replaced it was enough to meet federal requirements, not enough to deliver on the promises that had been made.